everyone. I'm Stephanie Rudine, the Director of Donor Engagement for the chapter. Thank you for joining us for another ALS Community Chat. Today, we're joined by Dr. Libby, who's a pulmonologist at the Providence ALS Center, as well as a board member for our chapter's board of directors and on the board of trustees for the National ALS Association. Today, Dr. Libby will be discussing the evolution of ALS care and the ALS clinics he's seen over the years. We're happy to have Jerry Landreth here today facilitating this conversation. Jerry was diagnosed with ALS in 2018 and lives in Hillsboro, Oregon. Jerry and Dr. Libby have gotten to know each other a little bit through both the Providence ALS Center, and we all attended Advocacy Day in Washington, D.C. in, I think it was 2019 together. If you have any questions or comments during the chat, feel free to just type them in and we'll see if we can answer them. Any questions for Jerry or for Dr. Libby? Thank you both for joining us. I'm really happy you all took some time out of your day. But now I'm going to pass it over to you, Jerry, so you can introduce yourself and start the conversation.
Great. Thank you, Stephanie. I'm honored that you guys would ask me to do this. It's a high privilege to interview Dr. Libby. Again, I'm Jerry Landreth. I'm just a regular person living with ALS. Diagnosed in the fall of 2017, and I am thankful for my team of the ALS Association and my team of doctors and support people. And Dr. Libby is definitely one of my support staff, my pulmonologist. And so, Dr. Libby, I'm wondering if you could just take just a second and introduce yourself.
Sure. I'm a physician and specifically a pulmonologist, a physician who works with patients with breathing problems. And I've been involved in the ALS Association for many years and have been seeing patients with ALS since the mid-1980s. I work with the Oregon Clinic and I work at the Providence Portland Medical Center, ALS Certified Treatment Center of Excellence, certified by the ALS Association nationally.
Yeah, thank you. Again, just to kind of clarify, do you mind if I call you Dr. Libby, or would you prefer Lou? Does it matter to you?
It doesn't matter to me. I'm fine with you calling me Lou, but if you're more comfortable with Dr. Libby, it's fine with me as long. And I should ask you the same thing. Should I call you Mr. Landreth?
Yeah.
Which is my routine when I first meet people.
That'll take me back to my teaching days.
Okay.
Yeah, Jerry is just fine. If you call me Mr. Landreth, it'll make me think that I'm teaching 5th grade again. So, very good. So I probably will continue to refer to you as Dr. Libby just because you're my doctor, but we'll see. Hey, before we get into all the nitty-gritty details, just quick, any hobbies? I feel like you're a tennis player. Is that correct?
Well, used to play a lot of tennis, and all my tennis partners got bad shoulders or backs or whatever, and they switched to golf. So now I play a lot of golf.
Okay. And do you have, just real quick too, do you have like a favorite food or a favorite dish that you want to tell us about?
Yeah. Well, for food in general, I love Italian food.
Very good.
There's a restaurant in Northwest Portland called Mingo that has a sugo de carne, which is basically a sweet coffee meat sauce on noodles. It is just wonderful, and they've been serving it for 15 or 20 years. And
that sounds great.
We usually go on my birthday, so that's probably my favorite meal. It's a little rich, but I love it.
Oh, nice. Well, we'll dive in here. Tell me a little bit about what is a pulmonologist and what inspired you to become one?
Sure. Well, probably very few people knew what a pulmonologist was until COVID came along, and now people at least recognize the name as one of the most important physicians taking care of the sickest of the sick of patients with COVID. So a pulmonologist is a physician who trains in internal medicine. That's the internal organs, the heart, the lungs, the kidneys, all those things. And then does a few extra years in one organ system, generally, like a cardiologist for the heart, or a gastroenterologist for the intestines, or a renal doctor for the kidneys, or a pulmonologist for the lungs. And the pulmonologists almost always train also in critical care medicine, because there's a big overlap between lung problems and critical care. The sickest of the sick can't breathe, basically. Mm-hmm. So we usually run the intensive care units where people end up on ventilators and more nowadays. And when you hear about the critical care units here in Portland or nearly anywhere in the country, it's usually a pulmonologist who's running it, and it's a pulmonologist who's staffing it, usually 24 hours a day. And I did that my whole career until the last roughly 5 years. I've stopped doing critical care. So I don't do overnights, I don't do weekends. And I've sort of backed off to what's considered a office-based outpatient pulmonary problem. So pulmonology in general is any breathing problem. The critical care is one aspect. The other aspect is outpatients with asthma, lung problems from smoking, lung cancer, fluid buildup, pneumonias. Sleep apnea is one of them now that pulmonologists take care of. So anyone with a chronic cough or a cough that goes on too long, all those things get evaluated by a pulmonologist. So I began doing more of that outpatient work about 5 years ago. In the last 2 years, I've just done ALS. If you don't have ALS, you generally don't get to see me. But that's because I'm on the retirement road, and this is a way of sort of cutting back to what interests me right now.
Yeah. Well, hey, speaking of ALS, I have kind of a two-parter question for you. Can you tell me a little bit about how you kind of started serving ALS patients, and then maybe piggyback on that, why you think pulmonology is such an essential service to us ALS patients?
Sure. Well, the first question could take up the next 20 minutes.
No, it's free.
But I'll abbreviate it down a little bit. So during my fellowship means that 3 years when you train just in pulmonary and critical care, I was interested in breathing muscles. And so I did some research in breathing muscles. And one of them was a little project with ALS patients, looking to see if a certain medication that works for asthma would work for ALS patients. The bottom line is obviously it didn't, or you would have heard about it years ago. But it got me interested because I met people with ALS, and I was intrigued with the personalities and the attitude. I was just amazed at these people. So when I came to Portland in 1985, right out of that fellowship, my partner said, "Do you have any special interests?" And I said, "Yeah, breathing muscles." And I was actually also interested in sleep apnea. So they said, "Well, you can run a sleep lab and you can take all the ALS patients." And I said, "Fine." And it's sort of, back in 1985, there wasn't a lot we could do for patients with ALS. But I saw the ones that were there, and I did what I could do. In 1988 or 89, a young guy who was my age, which meant 45 or thereabouts then, 48, I think. He was a year or two younger than me, came in the hospital with pneumonia and ALS that he'd had for 2 or 3 years. His name was Richard Burdell. And he ended up on a ventilator, and I took care of him for 10 years until he died in 1998. And his sister took care of him with a whole crew of caregivers, and they did fundraisers to pay for everything. And he lived in his little home in Northeast Portland, where actually the phone number for that home is now the phone number for the ALS Association. And believe it or not, so because his sister became the executive director of the ALS Association. But anyways, his dying wish was, "I want you, his sister, to set up a foundation that will take care of ALS patients like you took care of me, great care services, and raise money for research so we can find a cure." This is 1998. And his sister came to me and asked me to be on the board, and I didn't think she could pull it off, but she did it. And that was the start of the ALS Association here in Oregon. It was called the Richard Burdell Foundation the first few years, and then we transitioned to the ALS Association nationally and took on our present name. So that was sort of the start of it, and it's the same story that I had back in the 1980s as a fellow. I've been so impressed with the brave, heroic approach that ALS patients take to this disease. It just blows me away what they are willing to put up with and their attitudes and their willingness to help others, like you, Jerry. That's kept me involved from the beginning. So that's the basic story of how I got involved. I think you had another question also. What was the other question?
Well, the other part of that is kind of the why. Why is you kind of answered it? Why is
pulmonology
essential to ALS patients?
Yeah. Well, it's you know, as you well know, and everyone out there probably knows, ALS can be the arms and legs, it can be the voice and the swallowing, or it can be the breathing muscles. And 1% of the patients start with breathing muscles. Most start with the arms or the legs or the swallowing or the voice, but 1% start with the breathing muscles. But unfortunately, everyone eventually gets everything. It may take many years to get all three components, but everyone eventually gets weak breathing muscles, and the vast majority of patients with ALS die because of breathing muscle problems. And the really neat thing is we can do so much more now than we did back in the 80s and 90s with the various equipment we have. So that's the neat thing, and that's why I'm excited to stay involved.
Yeah. Tell me a little bit about this whole clinic model, and how did you get involved in ALS clinics?
Well, the clinic model is, well, I really give credit to Kim Goslin for getting us on that track. But even before Kim, there was always a desire to have sort of one-stop shopping for patients with ALS. And the ALS Association came up with this design for clinics, and a few big clinics in San Francisco and Philly and Boston started it. And then they sort of took that model and made it available nationwide. And the clinics that meet the highest criteria are called Certified Treatment Centers of Excellence. And they provide multiple services. Generally, it has to have a neurologist. Does not have to have a pulmonologist, but it has to have a respiratory therapist, someone who can measure the breathing capacity and give some advice. Has to have a social worker and PT and OT and speech therapy and swallow and dietitian and those sorts of things. So it has all those services, and you come to one place and get them all in one afternoon or one morning, or depending on how the clinic is designed. You know, every half hour someone else enters your room. And nowadays we do it virtually. You enter the Zoom room for a patient every half hour. We switch our rooms. So it's a really neat way for patients with mobility problems to be able to see 5 or 6 or 7 different disciplines in one afternoon, instead of spending 2 or 3 weeks to get those appointments and terrible travel problems. And on top of that, not only the travel problems, but now mobility problems. We can see people in Alaska. I saw a person in Alaska today.
Nice.
Because of virtual visit. It wasn't part of this Certified Treatment Center of Excellence. But if you meet certain criteria, you get certified as a Treatment Centers of Excellence. One of the other things that's required of that level of care is research. And so the Certified Treatment Centers of Excellence, and I think there's 73 of them now in the country, all are participating in research at one level or another. We're very involved, with Dr. Nick Olney being involved in lots of different studies, including what you hear about coming out of Harvard, the platform study, where they're studying 5 different things at one time and only need one group that's the placebo group. So you aren't having half the patients going to placebo. You have one placebo group and 5 treatment groups. So only 10 or 20% of the patients have to have the placebo. So it's a really neat way of doing it.
Right.
So we're involved in that. We're one of the sites for that. So it's a great program. There's other types of clinics. They're called recognized treatment centers, and we have one at in this state. We have OHSU, the VA, and Providence have certified treatment centers of excellence. That's pretty impressive for a state our size to have 3 certified centers. And then there's recognized treatment centers down in Medford, I believe in Bend, and maybe Kaiser here in town. And they do everything the other ones do, but they don't have the research component.
Gotcha.
But they provide the one-stop shopping.
Nice. That great explanation. Thank you. Since you're kind of hinting at research a little bit, What are there things that you're excited about for the future of ALS care and research specifically? I mean, you hinted at this one model, which I'm familiar with, which is a great idea, but anything else out there that you're excited about?
Well, I think there's a lot to be said for stem cell therapy, basically getting cells and promoting their growth as nerve cells, and then injecting them back into the spinal cord area and letting them settle where they should settle and start growing nerves again. That's really exciting. It hasn't been, there have been lots of trials in lots of places, and some like the neurone from Brainstorm has been encouraging, but their recent phase 3 study did not show a definite benefit, and they're going back and looking at subgroups and various things. But I think that's where a big breakthrough is going to come, stem cell therapy. And then the whole, the immune therapies, realizing there must be some inflammatory process going on, and if you can suppress that some, there'll be less activity of the ALS, and it'll slow it down. And I think in the long run, we're going to end up being more like cancer treatment. If you look at cancer treatment, people with cancer usually get 2 or 3 or 4 different drugs to try and suppress the cancer. If you give them one drug, it might work for a month or 2 or 3, and then it comes back. If you give them 2, it might go 6 months. But if you give them 3 or 4, sometimes you knock it out, it never comes back. For example, Hodgkin's disease, which is a cancer of the lymph glands, used to be, I had a college roommate, a good friend of mine, died from it in his 20s. Whereas today, he would have been alive still if he'd gotten it at this point. 90% of people are cured, even if it's gone all over the body, because they use 3 or 4 different drugs. So I think that's the future. And that's the goal of the ALS Association: find a world without ALS, discover a world without ALS. That's our goal.
Absolutely. So I'm not going to give your age away, Dr. Libby. We'll just say that you're 39. And over the course of your career, how have you seen ALS care evolve and change?
Well, I think the big change is, frankly, a patient like Richard Burdell, and he told me this, when he was diagnosed, even though he was probably 40 when he was diagnosed, and it was slowly progressive, he was basically told, "I'm sorry, there's nothing we can do," by his neurologist. "I'm sorry you have this diagnosis. You better plan for the worst. And on average, you're going to die within 2 to 4 years. And go home and make preparations." And that's all that was offered. I think there's so much more that we can offer nowadays, and that's what we offer in the multidisciplinary clinics like the Providence and OHSU and VA clinics. We offer multidisciplinary care. We OT and PT, mobility, communication, feeding tubes, and the respiratory equipment all make life so much better and lengthen quality life. Nothing that I've mentioned slows down the disease process. That's where the research has to get, so we can slow down the process. Maybe a few drugs do it, Radicava and Rilatech, but otherwise there's no drugs that definitely slow it down, and they only slow it down a little bit. But all the other things can make quality of life so much better, that we have a lot to offer. So that's been an enormous change. There was nothing for breathing support other than tracheostomy back in the 80s. But that changed. That changed because of sleep apnea. And sleep apnea, as you know, is a condition where people, usually men who snore, and they stop breathing at night. And we discovered if you put a little mask over their nose and a little machine that pushes air a little gently, it'll open up the airway and they don't stop breathing. Well, once we realized you could put a mask on and push a little gentle air, you realize you could put a mask on and push more air all the way down in the lungs and replace what the diaphragm does. So we could literally ventilate patients using a little machine called Bipap. Now it's usually called AVAPs, but Bipap was a common name in the 80s. And I remember very well when one of our local patients named Steve White came to me, and I'd measured his breathing, and he was pretty darn low, and he was on the Bipap machine. And I said, well, you're at the point where we have to talk about a tracheostomy. And he said, well, I don't want one now, but I will want one in the future. But I think I'm doing just fine on the Bipap. And we had that conversation every 3 or 4 months for about 3 or 4 years. And eventually he was on that Bipap machine 24 hours a day. And he lived many, many, many more years of good quality life on that Bipap machine. Wow. Because it could breathe for him. His diaphragm was gone, but he continued to breathe. And he was on the board of the ALS Association. He wrote the first manual. It was called the White Manual, not after him, but because it was an old white book, and it went through everything you might be experienced with ALS and the approach to it. Unfortunately, he eventually died from respiratory causes, but he lived many, many years without a tracheostomy because of the ventilatory support we could give with a little mask. So that's been a big, enormous change that I've seen. I think in terms of respiratory, that's the biggest change. The other change, those cough assist machines people use help clean out the lungs and prevent pneumonia. Those sorts of things are add-ons that help a great deal.
Wow. That's great. Is there anything, Dr. Libby, you would want to share in regards to like what it's been like these years being on the national board or being on the board here in Oregon? I'm assuming that's rewarding work because you've done it for some time now.
Yeah.
Any kind of shout outs you want to give to being a board member?
Sure. Well, it's been extraordinarily rewarding taking care of patients with ALS. They really are the inspiration for me to do the work. And we've had ALS patients on the board both locally here in Oregon and nationally. Right now, I think there are 3 patients with ALS on the board of trustees at the highest level out of, I don't know, 22 or 23 board members. The board work is hard. It's committee work. There's a lot of Zoom meetings. There's a lot of controversies. There's a lot of politics, so to speak. There's the yin and yang of national and chapters. There's money issues, anything you can imagine in a business. But everyone who's on the board locally or nationally is committed to patients with ALS. And that's why I can deal with all the politics and the money issues and the controversies, realizing everyone wants the same thing. They just may want it in slightly different ways. But everyone is inspired by the ALS patients and their stories. I guess the only other shout out I would give, I wouldn't have been doing all this stuff. Obviously, Richard Burdell and his sister started me. Kim Goslin kept me involved. She invited me to the clinic, even though I was the first pulmonologist in the country to go to a clinic. The rest of them had respiratory therapists by definition, but none of them had a pulmonologist until I went. And now there's probably about 10 out of the 70 who have pulmonologists, because a pulmonologist is not nearly as important as a respiratory therapist. They all have to have an available pulmonologist. They just don't have to come to the clinic every week.
Gotcha.
But so Kim Goslin's been an inspiration. And then there's Lance Christian. And Lance has encouraged me to stay involved in the board locally. He nominated me to be on the board nationally. He's a fantastic person. He's been a fantastic leader for our ALS community in Oregon. So I'll shout out to him also.
Yeah.
And he has a wonderful staff, including Stephanie, who's on this call, as you know.
Oh, we are very, very thankful for our ALS Association here in Oregon and Southwest Washington. I am consistently humbled by all that they do for me and for us. And for you, Dr. Libby, I am honored that I've had this opportunity to, well, not only to get to know you, to interview you, but I couldn't ask for a better doctor and friend. I consider you a friend as well. So it means the world to all of us, what you've been able to do over the years, and specifically now for me and for all of us. We're so thankful for your hard work and dedication, Dr. Libby.
Well, thank you. And I consider you a friend also, Jerry. And like I said in the beginning, you can call me Lou, but I know it's not possible for you. But we spent that week in Washington together up on the Hill, and that was great. And
Yeah.
we really got to know you, but I consider you a very good friend also. I'm honored to take care of you and help you.
Yeah, thank you. Is there anything, Dr. Libby, anything that you wished I would have mentioned or brought up? Anything that we forgot to talk about?
I thought you were going to ask me what my favorite dessert was. You asked me about my favorite meal.
Well, yeah. Okay, quick.
Well, chocolate, forget it. It's got to be chocolate.
Okay.
I'm a dark chocolate addict, admittedly.
Well, that's good.
I'll drink an occasional beer, but I'm not addicted to anything but chocolate.
Oh, very good. Well, I can't tell you how much fun this has been for me. I'm no Larry King. I don't have any suspenders or anything, but I have enjoyed thoroughly this opportunity to interview you and to put the spotlight on an appropriate part of ALS care, the pulmonology. So, Dr. Libby, again, heartfelt thanks for all your hard work and all you do for us. And I think we'll probably just kind of close it off there. It's been a great opportunity for us to put the spotlight on ALS, and I am glad that we had this chance to do this. So I think we'll go ahead and conclude our interview. So
thank you very much. And if you need a recommendation for a job at CNN or any of the big cable networks as an interviewer, you got it from me. You made it easy for me. So thank you.
Thank you. It's been fun. So, all right. Well, I think that's it for us. And then I think we can go ahead and just leave it there.
Very good. Call it a wrap.
Okay.